Hi, everybody. This is another catch-up lecture. We're actually going to try and catch up to one more ECG lecture that we hadn't done before. Hopefully this one will go a little bit easier than the last one. I hope so. We're just going to try it because in this case, we don't have any videos and things like that. Zoom has tried something new to help people present a bit better. Unfortunately, it doesn't really work too well with the videos. So this one here, because it doesn't have a video, it should work a lot better. So you're actually going to see me on here. Hi. So now I'm there, and I'm going to make myself just a little bit smaller, move myself a little bit out of the way as well. And I'm just going to do a few things just so that we make sure everything is done correctly. We just have to optimize things and things like that. Seems like everything's okay. I hope so. Let's see how that goes. I just want to optimize all of this, make sure everything is okay, but it seems like that's all right. Okay. All right. Sorry, just wanted to make 100% sure that that's okay and that it will be good enough for us as we're doing it. So like I said, we're going to do another ECG one now. I hope you'll be able to see my pointer. It should be quite apparent because it's quite a large one. So, but you guys will give me feedback after that just to let me know if it was okay or you couldn't see it all right. Okay. All right, so let's go. So we've got another ECG that we're going to look at today. And I hope at this stage you guys realize that ECGs, while they may seem quite intimidating, are actually quite easy once you break them down. So again, let me move myself a little bit, just so that you guys will be able to see everything. Make myself nice and small. And I'm going to put myself somewhere towards the bottom so that even when we're looking at the ECG and the next time, you can just see it a little bit better. So this is another scary looking ECG for most people. When you see something like this, because it doesn't, what is going on here? Because you've got an 81-year-old woman with palpitations and generalized weakness. So what does that mean? I mean, if she's got palpitations, so what? I mean, is she hypovolemic? Is she pyrexial? Weakness? All our 81-year-olds have weakness. And if they don't, then you get worried. Why aren't you weak? You should be weak. So let's have a look at it and see what's going on. I'm just trying to make sure I actually pulled up the right one over here. Okay. So the first thing that we do, sorry, I was just making sure it was the right one that I had up. So the first thing that we do is let's have a look at our axis. So we've got one pointing upwards and got AVF pointing upwards. That means we've got a normal electrical axis. Let's have a look at the rhythm. So the first thing I want you to have a look at is P waves. Now we're going to move on to the big one so that you guys can actually have a better look at it over there. So let's have a good look throughout here and try and find the P waves. So remember what we said, V2 should be the place where you see P waves, but if you don't, then you need to start looking in other places as well. So let's start looking, where can we see a P wave? You see that we see a lot of T waves, a lot of T waves there, a lot of T waves there, a lot of T waves there, a lot of T waves there. Come again, T wave, T wave, T wave. Is that a little P? It's possible, but we're not sure. Let's have a look at another T wave. Maybe a little P there, but these P's are not really coming up. So we can't really see a good atrial activity anywhere. Here we see something, and that's what we're going to get to just now, right? Even here too, we just see something. But let's go to our rhythm strip. So the first thing that we can say is that we don't have regular P waves, all right? So we can't really talk about a PR interval, so we don't know what's happening over there. And we can't say that a QRS follows every P because we don't have a definitive P wave that we can follow. So the only other things left in our rhythm are to check our width of our QRS complexes and check the regularity of our QRS complexes, right? So first let's look at the width. So the width is quite narrow. So if the width is narrow, it tells us that the AV node is getting its signal either from the SA node or from the junction, AV junction, but it's not producing its own signal because then we'd have a wide complex, QRS complex, all right? So this tells us one of two things. Number one, either we've got an SA node that's functioning, but we just can't see it, or we've got an AV node that's functioning, or a junctional node that's going quite fast. Okay, so let's try and have a look and see what's going on. Now, the particular one that I want to look at over here is, let's look at the regularity, which is the next thing. So the one thing that you'll notice is it's quite irregular. Actually, it's very irregular when you really look at it. You sometimes get QRSs that are quite close, and they're quite far, then they're quite close again, then they're quite far again. So something's causing them to be quite irregular, right? And if we look at our rate, if we take, our rate is always taken as the two closest, the two QRS complexes that are closest to one another. Let's take this one, for example. It's quite close. We're looking at a heart rate of over 150. Let's put it at about 160. So we've got quite a definitive tachycardia that's going on, and we've got a narrow complex tachycardia. So let's revise and think about our narrow complex tachycardia. So number one would be a sinus tachycardia. In other words, we'd expect to see atrial activity. So we don't have atrial activity. Number two, we could see atrial flutter, but then we need to see flutter waves, which means that we should be seeing P waves along the way, somewhere along here, which we don't see. So we can take out atrial flutter already. We could say multifocal atrial tachycardia, but the whole definition of multifocal atrial tachycardia is that we need to look at different P wave morphology, so we don't have that. So that leaves us with what possibilities? The possibilities that we have are atrial fibrillation and supraventricular tachycardia. Okay, so we're still going to cover supraventricular tachycardia, but let's, for the sake of learning, let me just tell you that supraventricular tachycardia is extremely regular, extremely regular. It's always at one particular rate. So if it's at 165, it will stay at 165. It won't change. It may start, it may go a bit up, may go a bit down, but generally it stays the same. So this brings us to our little patterns that we see over here. And if you look at this, now somebody may argue that it's a flutter wave, but it's not really, because you've got a T wave and then you don't really have, you've got one or two discernible, possibly discernible, but when you're looking along the whole thing, you don't actually see P waves anywhere, any discernible P waves. So this is what we call atrial fibrillation. Now you may ask me, is it not a junctional rhythm as well? No, junctional rhythms are also quite regular. Because remember, the junction is a pacemaker cell, so it's still giving off its signal quite regularly. So you don't get this irregularity that you are seeing over here. So this is quite typical of atrial fibrillation. So let's look at the criteria for atrial fibrillation. No discernible P waves. Sometimes you see the fibrillation line. So this would be closer to a fibrillation line. And sometimes it's quite a bad, jagged fibrillation line. All right, so you've got indiscernible P waves, or P waves that are, or a fibrillating line where the P wave should be. You can't talk about a PR interval. You have narrow QRS complexes, but they are extremely irregular. All right, so those are the criteria to say that it's an atrial fibrillation. All right, and we've got quite a significant tachycardia over here. The thing is, with atrial fibrillation, what you'll find is, compared to most of the other tachycardias, when you put your patient on a SATS monitor, right, even before you've done an ECG, even before you've done anything else, your SATS monitor reads 64 beats per minute, 185, 92, 67, 129, 82. It just keeps on jumping all over the place because it keeps on trying to keep up beat to beat, beat to beat, beat to beat, and it can't really do that. Okay. So that's one of the other clues. So we already know that we are most likely dealing with an atrial fibrillation. All right. The only other thing, like I say, that we could possibly say that it might be, although it's very unlikely, is an atrial flutter, but it doesn't really look like it over here. All right. So if we suspected it was an atrial flutter, we would do a rhythm strip for about 2 to 3 minutes and see if this, like a sawtooth pattern, starts to develop. I think we had seen it on one of the other ECGs, but I doubt very much that we would ever pick it up on this. All right. So let's look at each zone and see if there's anything that we can pick up in particular. So if we look at this, if we look at the inferior zone, we notice we're not finding much in terms of ischemia. We're not finding much in terms of hypertrophy and things like that. If we come across to V1 and V2, which are the septal leads, we see that that's the expected pattern. That's what we should get. We could argue that these T waves are a bit flattened, but we don't have a history of chest pain. We're not really suspecting an ischemia in this case. All right. In V3 and V4, we start to see a bit of a depression over there, as well as in the lateral leads V5, V6, leads 1 and AVL. Remember your high lateral leads. Now the thing is, tachydysrhythmia, so in other words, AF, SVTs, all of these, if you get just ST depressions in the lateral leads or even the septal, it's not such a major issue. It is to be expected. If you start seeing them, however, in the inferior leads, if you start seeing them in AVR, V1, V2, then you've got to consider ischemia. And we talked about that in another talk as well. Okay, so we're not going to worry too much about this. To be 100% safe, of course, you can always do cardiac enzymes. There's no problem. So we know that there's no real signs of ischemia. And if we come to AVR, we also notice there's not too much going on over there. So from our zones, what we've come out to is that we know that this is most likely an atrial fibrillation. All right, so what is atrial fibrillation? So I'm just going to increase a little bit here, not because I'm handsome, but just because I want you guys to understand what I'm saying. So you've got this atrium that's sitting over there, all right? And like even with the ventricle, it's just fibrillating. It's just doing that, all right? So that's all that it's doing. Now, the good part is because fibrillation of the atrium is a very small muscular thing, it generally takes a long time to cause a lot of problems, all right, as compared to ventricular fibrillation. But I want you to just understand why fibrillation is a problem in general. Do this exercise with me now. Take your hand and do this. Simple. Do it. Can do it. There's no problem. Can do it for half an hour. Can do it for an hour. Probably still be okay. Now take your hand and start doing that. Just start doing uncoordinated movements, right? Similar to what a fibrillation would be like. Now, I don't know about you, but I'm already starting to feel a little bit tired. My hand's not feeling 100%. It doesn't feel like I can keep it up for that long. So even when you've got ventricular fib or atrial fib, eventually there will be a loss of ATP within those cells. So you do have to be careful. However, with atrial fib, and let's just make sure we are dealing with atrial fib. I'm just going to go across to the answer just so that we can see what's going on. So atrial fib, let me just decrease my size over there again. Increase it just now, right, just so that you guys can see everything. So here we have atrial fibrillation with a rapid ventricular response. So what that means is even though it's fibrillating, quite a few of those signals are getting through to the ventricle, a rate of 155, so we're a bit off, said closer to 160, but not too bad. So ECG rhythm is a narrow, complex, irregular tachycardia. The differential diagnosis is atrial fibrillation, atrial flutter with variable AV conduction. That means, you get atrial flutter, but it's sometimes 2 to 1, 3 to 1, 4 to 1. But remember with those, you'll see flutter waves, which we didn't see in this one. And multifocal atrial tachycardia, multifocal atrial. So that means you must have different morphologies of your P wave, all right? distinguishing between these three entities is based on the close evaluation of the atrial activity. So we're not too worried about the ventricles. So here we go. Atrial flutter associated with regular atrial activity flutter waves. Very good. MAT would be associated with irregular atrial activity. And when it's irregular, that means both in terms of your PR interval, your morphology, sometimes even conduction, but not as common, all right? So in these ones here, in MAT, there must be at least three different morphologies for the diagnosis to be made. And I'll show you an MAT later on, because MAT in itself is more a sign of COPD and lung disease. So we're not really looking at it as a major cardiac problem initially, all right? And atrial fibrillation will not be associated with any notable atrial complexes at all. So we were correct in saying that it's an atrial fibrillation. Now, I cheated. I looked at the answer before I started telling you guys because I need to look intelligent. If I don't get that, that satisfaction of showing you guys that I'm actually very intelligent, I just go into a depression. No, I'm just kidding. So it's just to make sure that I teach you guys the right thing. So I've just broken it down for you here. Atrial fib, narrow complex tachy, but irregular. Atrial flutter, narrow complex tachy, but regular with flutter waves. Now that's just a normal atrial flutter, which is the more common one that we see. Atrial flutter with variable AV block is not as common, but it does happen. So this is the more common one that we see, all right? And multifocal atrial tachycardia, narrow complex tachy, but generally irregular. You tend to get a lot of irregularity simply because of the COPD. Your sinus arrhythmia is a lot higher. And because of the changes in the atrial activity, because the atrium is pumping out at different strands at different, well, if you look at the P waves, some of them are long, some of them are peaked, some of them are shallow. So all of this affects the ventricular response. So they tend to be irregular, but you can get very regular ones as well, all right? So an atrial fib would be what we call irregular. Atrial flutter, if it is regular, it's regular, and sometimes it can be regular, irregular. Multifocal atrial tachycardia tends to be regular, irregular, more commonly. In other words, you'll find because the morphology is changing, but because the morphology is constant. So, for example, you've got a tall wave, a short wave, and then a thick wave. It tends to repeat. So you get this regular, irregular pattern, all right? But there must be at least three different types of P waves. Now, it's a very difficult diagnosis to make. It's a very technical diagnosis and not something that we need to do all the time, all right? But just so long as you guys know that that's what it is, okay? Right. Let me just see. I think I've got one more slide for you here. Just want to go through one thing. Right. So the management. This is where, let me just go back for a second. All right. I just want to explain a bit of pathophys for you. So what happens with atrial fibrillation is that you've got this atrium that's fibrillating, having a good fibrillation over there. So what's happening to all that blood that's sitting inside over there? What do you think? It's not really getting pushed, right? So it's not coming out of that atrium into the ventricle. It's kind of just sitting. So what happens with blood when you leave it alone? It doesn't play video games. It starts to clot, all right? So we start getting multiple thrombi within that atrium, okay? So if you have multiple thrombi within that atrium, the last thing you want those thrombi to do is to embolize. All right. So this is where management becomes very important. We are trying to make sure that we don't cause more harm by embolizing the thrombi that are present. So there's a few things. Number one, if you have definitive proof that it's less than 48 hours. Now they say even 2 weeks, but I'll be honest, 48 hours since the onset, my apologies for that. 48 hours since the onset of your atrial fibrillation. That means you need to have a confirmatory ECG. So the patient came a day before, 2 days before, and you did an ECG, you read the ECG, everything was fine. And 2 days later, the patient comes in with this tachycardia that's related to atrial fibrillation. you can attempt rate control by chemical or electrical cardioversion. All right. Now, what I will tell you is that blood, if any of you have drawn blood and put it in a little tube, just leave it for a little while, not even an hour, not even 48 hours. You already get some clotting going on. So even though it's less than 48 hours, you can't be guaranteed that there are no clots inside there. All right. Now, the problem is if you suddenly stop that heart from functioning in a fibrillating pattern, in other words, you get that atrium pumping properly, it's going to start pumping out all of those thrombi. So, what will happen is you will now get a patient who's embolizing all over the place. Basically, what I'm saying to you is do not attempt rate control in atrial fib. Just don't do it in an emergency department. Let the cardiologist do it because of medical legal reasons. All right. If it's more than 48 hours, now I'm teaching exactly what the book says. More than 48 hours of unclear history, your treatment is anticoagulants. All right. Clexane, all right, and warfarin. And remember, Clexane is always given before warfarin. Okay. And the question is why anticoagulants and not rate control? Because rate control can always be achieved. We have to make sure that there are no clots sitting in that atrium. All right. So what happens is, let's say we control the rate for whatever reason. We give this patient amiodarone, we give this patient cardioversion, we place this patient on beta blockers, whatever it may be. So as we slow down the rate, there's a greater chance that that atrium is going to push off. It's going to go into a normal sort of function, and then it's going to shoot off every single clot. So you're going to have a patient with a wonderfully functioning heart who's paralyzed down the left side of their body, has lost a finger because they've embolized there, all right? Suddenly has acute renal failure. The patient's penis falls off, you know? It can happen. You don't know where these where these embolies are going to go. So you cannot, I repeat, cannot in an emergency department make a definitive diagnosis that you are definitely going to control this rate. Only time it becomes an issue is if this tachycardia is causing severe instability, all right? And if it's causing severe instability, what we would do in that case is that we would actually most likely thrombolize the patient first. Now, luckily, we've never had to do it. The majority of your AF patients come in exactly as our patient presented. They're tired, they're weak, they're having palpitations, but they're not dying. The ventricle is still pumping quite well, so their BPs are staying up. But let's say you are working and you are that unlucky doctor who gets one of these. If you really had to control that rate in order to prevent the side effects of, or to prevent the sequelae of, what you call it, tachycardia, you'd be better off thrombolizing that patient and thereafter trying to control rate. But that's a very rare situation. So just keep it at the back of your mind, but don't do it. So basically, it's nice when an atrial fibrillation patient walks into your emergency department. In fact, when it happens, I clap my hands because all it means is I have to write an admission form, do an ECG, start the patient on Clexane, send the patient to the ward. It's the physician's problem. It's not my problem. I've done what I can. So you should be happy when an AF walks in because it's one of the easiest patients to treat. Okay. So this is why we do anticoagulation and not rate control. Now, we're going to discuss supraventricular tachycardias at one point. And it's important to know that there's a difference between the two because the way that we treat supraventricular tachycardias is with rate control. So it's very important not to mix up atrial fibrillation and supraventricular tachycardia. If you, for example, have a patient with supraventricular tachycardia and you give them Clexane or warfarin, you might as well have given them Smarties because you've done just as much to assist them. By the same token, if you have a patient who's got AF, atrial fibrillation, and you mistake it for supraventricular tachycardia, and you shock them or chemically cardiopathy them, you most likely kill them. So it's important. If you're not sure, ask, but at least recognize that something is going wrong, all right? And like I told you before, the biggest initial clue on your SATS monitor is what you call it, very irregular heart rate on that SATS monitor. So you'll just see it flying up and down all the time. And when you see that, put an ECG on, and 99% of the time, you will find that it's atrial fibrillation. Not always. You get PVCs, you get PACs that are causing problems. There's lots of things that can cause it, but the most common, atrial fibrillation. Okay. So I hope you guys enjoyed that one. A bit shorter than the others, and I'll try and put another one soon. Okay, I hope this format was okay as well. I hope you could follow my mouse. And if you couldn't, please let me know, then I know I won't use this format again. Okay, guys, thanks a lot. Really appreciate it. And we'll have another meeting soon. Bye.